Hello, I'm Dr. Kyle Fratta. I'm the EMS Fellow at Johns Hopkins University and an Associate Medical Director at Howard County Department of Fire Rescue Services. How many times have you responded to a call for a sick person to find that your patient is tremulous, diaphoretic, hypertensive, or tachycardic? Did you consider alcohol withdrawal as a possibility for their symptoms? Patients presenting with alcohol withdrawal symptoms are more common than you might think. Up to 40% of the population reports heavy alcohol use or alcohol use disorder during their lifetime. About half of patients with alcohol use disorder experience withdrawal symptoms after decreasing their alcohol intake. Alcohol withdrawal syndrome occurs with the sudden cessation or reduction in alcohol consumption. It may often present with only mild symptoms. However, severe withdrawal symptoms, including delirium tremens, can be fatal if not treated promptly. The mortality rate for untreated delirium tremens is nearly 37%. Currently, many patients receive minimal pre-hospital supportive treatment. A quick glance through the current Maryland medical protocols for EMS reveals few references to alcohol use as a medical emergency and little guidance on how to treat these patients, particularly those presenting with symptoms of withdrawal. In contrast, research reveals that alcohol use disorder is one of the most significant healthcare problems worldwide. The 2025 Maryland Medical Protocols address the need for a growing population of patients struggling with alcohol use disorder by introducing a new protocol for the treatment of alcohol withdrawal. In this module, we will first discuss how to assess the severity of alcohol withdrawal symptoms, and then review the recommended treatment based on the severity scoring. Several scoring systems are used to assess the severity of alcohol withdrawal symptoms. The one selected for use by Maryland EMS clinicians is the Brief Alcohol Withdrawal Scale, or BAWS. BAWS was chosen because it is relatively quick and easy to use. Scoring is based upon 5 signs and symptoms: tremor, diaphoresis or sweats, agitation, confusion or orientation, and hallucinations. Each component of the BAWS is rated on a scale of 0 to 3, with 0 being asymptomatic and 3 being severe. For tremors, you can see that no tremors are scored as a 0. Mild tremors that are not visible but can be felt by the patient are scored as 1. Tremors that are visible when the patient's arms are extended are considered moderate and are scored as a 2. Severe tremors that are visible when the patient is at rest without their arms extended are scored as 3. When assessing diaphoresis or sweating, no sweating is scored as 0. Mild or barely visible sweating is scored as 1. Beads of sweat are considered moderate and scored as 2. And drenching sweats are rated as severe and scored as 3. Agitation scoring is based on the Richmond Agitation Sedation Scale, or RASS. Patients who are alert and calm are scored as 0. Those who are restless, anxious, and apprehensive with non-aggressive movements are scored as 1. Agitated patients with frequent, non-purposeful movements are rated as 2. And patients who are very agitated or combative and may be violent are scored as 3. In rating orientation or confusion, patients who are oriented to person, place, and time are scored as 0. Patients who are disoriented to either time or place, but not both, are scored as 1. Note that in assessing time, a patient is considered disoriented if they are wrong by more than 2 days, or report the wrong year or month. Disorientation to place would include incorrect name of the building, city, or state. Disorientation to both time and place is scored as a 2. And a score of 3 is for patients who are disoriented to person, in addition to place and time. Finally, consider visual, auditory, or tactile hallucinations. No hallucinations are scored as 0. Mild hallucinations include those that are vague in nature, with the person still having an intact sense of reality. These are scored as 1. More defined or detailed hallucinations are considered moderate and scored as 2. And severe hallucinations, in which the patient is obviously responding to internal stimuli, such as voices or visions that are not observable to the examiner, and have little to no sense of reality, are scored as 3. The BALL score is determined by adding the scores from all 5 signs and symptoms together. A BALL score of less than 3 is considered mild alcohol withdrawal. A ball score of 3 or greater is considered moderate to severe alcohol withdrawal. Let's take a moment to practice using the BALS scoring method. Your patient has no tremors at rest or with their arms extended, is mildly sweaty, restless and anxious. They're oriented to person, place, and time, and they deny hallucinations. Their BALS score is 2. This is considered mild alcohol withdrawal. Now consider a patient with obvious tremors at rest, drenching sweats, obvious agitation, but not combative or violent, oriented to person, place, and time, and they deny any hallucinations. The BALS score for this patient is 8, which is considered moderate to severe alcohol withdrawal. BLS treatment for alcohol withdrawal includes placing the patient in a position of comfort, if possible, based on the patient's condition, assessing the blood glucose level and treating as indicated, and determining the BALS score. BLS clinicians should request an ALS response for a BALS score of 3 or greater. ALS treatment includes cardiac monitoring and establishment of an IV when the patient's condition allows. For mild alcohol withdrawal, a BALS score less than 3, administered ondansetron is needed for nausea. Note that for patients 18 years of age and older, droperidol may also be administered per the nausea and vomiting protocol. For moderate to severe withdrawal, a BALS score greater than 3, or a known history of severe alcohol withdrawal, administer midazolam 2 to 2.5 milligrams IV. This dose may be administered an additional 2 times for a maximum of 3 doses without medical consultation. Midazolam dosing should be titrated to the reduction of psychomotor symptoms and relief of anxiety and agitation. If an IV isn't available, 5 milligrams midazolam may be administered via intranasal or intramuscular routes. All additional intranasal or intramuscular doses require medical consultation. Be sure to obtain a 12-lead ECG when the patient's condition allows, to assess for the long QTc or arrhythmia. A medical consultation is required for patients less than 13 years of age, and additional doses of midazolam beyond the 3 IV doses previously mentioned, or any repeat intranasal or intramuscular doses beyond the first dose. The changes to the indication and dosages for midazolam, ondansetron, and droperidol have been included in the pharmacology sections as well as on the protocol page. You are caring for a 47-year-old male patient whose family called 911 reporting he is not acting right. The patient reports he typically drinks a fifth of vodka a day, but has had no alcohol for the past 24 hours. The patient is conscious, alert, and oriented to person, place, and time. You note that he has beads of sweat all over his face. He has continuous tremors at rest and appears restless and anxious. The patient does not appear to be hallucinating. The BALS score for this patient is A, 1, B, 3, C, 6, or D, 8. The correct answer is C, 6. You are on a BLS transport unit. Due to the BALS score of 6, you should request an ALS response to assist with this patient. A, true. B, false. The right answer is A, true. An ALS response should be requested for patients with a BALS score of 3 or greater. The correct dose and route of administration of midazolam for this patient is A, no midazolam is indicated. B, 2 to 2.5 milligrams IV. C, 5 milligrams intranasal or intramuscular. D, both B and C are correct. D is the correct answer. Midazolam may be administered as either 2 to 2.5 milligrams IV or 5 milligrams intranasal or intramuscular.